Good afternoon, everyone. Thank you for joining Elder Abuse Prevention Ontario's webinar on elder abuse and COVID risk and preventive factors. We are joined today by Dr. Gloria Gutman from Simon Fraser University. As many of you known, we did this webinar prior to, had some technical issues. We had done a test yesterday and we're hoping that we have less interruptions today. If we do encounter major disruptions, or get feedback from you as participants, we'll try to bear with it as we go through. Unfortunately, we've tried our best to try to resolve these situations, but we are going to allow everyone to have the opportunity to hear Gloria's presentation because she has such great information to share with us today. So just some logistics that we have, everyone's microphone and audio will be turned off during the session. We have an ASL interpreter with us today. You can drag the line across to increase the size of the images of our speakers as well as the interpreter if you want as well. And I believe you can also pin the interpreter so that person stays on your screen at all times. The webinar is being recorded today and will be posted on our website as well as the Canadian Network for the Prevention of Elder Abuse after the webinar, probably next week as well. If you have a question as we go through the webinar today, please put that in the Q&A box, and Laura, my colleague, will answer those during, and also have a question and answer period at the end of the session as well. There'll be a pop-up menu that comes up after the webinar to complete a short survey. We would appreciate you completing that at the end of the webinar to give us your feedback on today's session as well as future webinars. So before we get going, I do want to thank the Sign Language Interpreting Service Association of Ontario, who's providing support for all of our webinars as we move forward to increase our accessibility across Ontario for people to access our webinars and information. For those who aren't familiar with Elder Abuse Prevention Ontario, our mission is to make sure that seniors are free from abuse, have a strong voice, feel safe and respected. We work collaboratively with our community partners to raise awareness, deliver training and education. We work with many, many community organizations, both at our local, regional and national level, to increase that service coordination and navigation of services and supports for seniors, as well as some advocacy work to promote the rights and dignity of older adults. As our mission indicated, our mission is really to stop abuse and restore respect. And we really all have a role to play in that goal. We'll talk a little bit today. I know Gloria will talk about some of those actions and initiatives that have gone on, about risk factors and some projects that have been in place. We as an organization are mandated through the Ontario Ministry of Seniors and Accessibility to implement Ontario's strategy to combat elder abuse and have been doing that since 2003. So we appreciate the funding and support through the Ministry of Seniors and Accessibility to continue implementing the strategy in Ontario to increase the quality of life and health and safety of older adults across Ontario. So these are our three priorities, as I mentioned, that coordinating services, we do that training and public education and awareness. Many people probably are familiar with World Elder Abuse Awareness Day that took place on June 15th. We did many education and presentations during that week, and if you want to see some of those webinars, we appreciate you can go to our website and access that information. We're doing this collaboratively with the Canadian Network for the Prevention of Elder Abuse. They are a provincial or national organization that fosters a collaboration exchange of reliable information and advances the programming and policy development on issues relating to the prevention of elder abuse. You can find out more of their information at their website, which is www.cnpa.ca. So today, Gloria is going to give an overview of the client disasters and how they've related to the deaths and how the economic and social consequences impacted older adults and how we're seeing a shift in the national spotlight around morbidity and mortality. I'm going to let her give some further direction on her presentation, but really focusing on those risk factors that many of us are aware about, but how during these times, including COVID, that we've seen seniors being traumatically affected. So just to give you a background about our speaker, Gloria resides in British Columbia. She is a director or developed the Gerontology Research Center and Development of Gerontology at Simon Fraser University. She's both she has roles in both the Canadian Association of Gerontology and the president of the International Association of Gerontology and Geriatrics, and also the president of the International Network for the Prevention of Elder Abuse. So we're quite pleased that Gloria has joined us today to share her wealth of experience with us as today. So Gloria, if you just click the screen, you can begin advancing the slides.
Okay. How do I get it?
Just click just go, yep, just go back, just like you normally would. There you go.
It's not letting me. Okay, it's not letting me. Well, good afternoon for those of you who are on the East Coast. Good morning for those of you on the West Coast. A number of you will know me from work that I've done in the area of elder abuse. What you may not know is that I also have done work for some years in the area of older people and risk of disasters. And so what I would like to do today is to take you through our situation with COVID from the perspective of someone who's worked in the area of disasters. So to review some of the evidence of older people that are at risk in disasters, to look at some of the new data we have on COVID, and particularly to talk about age and sex and some of the other differences, and then to end up with some of the new kinds of abuse that we're seeing. So I want to draw your attention to the International Classification of Natural and Technological Disasters to sort of see where the pandemic fits. As you'll see, there's two classes. There's natural disasters and the technological disasters. And the pandemic fits under, on the natural side, under biological. But what we want to note is that over the years, Canada has seen its fair share of each type, including in previous pandemics. In 1900, we had in the 1900s and 1918, we had the Spanish flu, which killed an estimated 50,000 Canadians. We had the swine flu pandemic in 2009, where the deaths totaled 428. We had the SARS outbreak in 2003, where there was only about 44 Canadian deaths. But, okay, can you give me the next slide? Next slide, please, Rayanne. Oh, there it is. This is a timeline of Canadian disasters. And what we see here is that in recent years, it's mostly been climate related. And this has been a worldwide trend as well as in Canada. But for us, we've had relatively few deaths. And so what we've been focusing on really has been the psychosocial aspects and the financial aspects. But one of the things that an important difference between a pandemic and these natural disasters, floods, hurricanes, and so on, the two key differences is that in a pandemic, you've got the risk of disease transmission, and secondly, there's differences in the duration of the event. when we have a hailstorm, it's maybe one day. Even with forest fires, it's a few days. But with a pandemic, as we're seeing with COVID, it could be months before we're out from under. So that makes a big difference. But what COVID has done, next slide, please. We have the next slide, right? Okay. So depending on the type of emergency, various groups within our population will be at increased risk of experiencing social and or psychological problems. They'll be at increased risk of some economic problems. But really the subgroups there's various subgroups that will be more at risk with one disaster than with another. And then comes the question again, next slide, please. Whether we're talking about morbidity or mortality, or we're talking about economics and psychosocial. Well, in the case of COVID, very much our attention has been turned to morbidity, sort of who gets the disease, and the issue of who dies from the disease. So those are two different things. And a lot of people will get infected, but it could be a relatively minor infection. But age is very clearly a risk factor for death, regardless of what type of disaster you're looking at. And I became very aware of this back in 2004 when we started hearing about the tsunami in Indonesia. And some statistics started coming out saying that it wasn't the nursing mothers and the babies who were dying in the tsunami, but rather it was old people. And being a gerontologist, that sort of captured my attention. But if we could have the next slide, please. But what really got me was during Hurricane Katrina, when it became very clear that as you look at this slide, you see as age goes up, the deaths go up. So it's really the old people and being who are at highest risk. So at that point, I got in touch with Margaret Gillis at the Public Health Agency of Canada. And I said, Margaret, we really need to be concerned. We've got old people who in this disaster, and when I look back on previous disasters, are very much at risk. What are we going to do about this? And so what some of you may remember was in between about 2005 and 2015, there were a number of conferences that were held in Canada, and we did do some work in this area. But as I said, before, mostly it was in conjunction with weather-related disasters. So next slide, please. This is a slide showing brand new hot data on mortality rates in various countries that are comparable to ours. And we see in USA, in UK, in Italy, Germany, France, Spain, the trend is the same, that it's the old people that are getting hit the hardest when it comes to who dies from COVID. Next slide. Next slide. But what about the vulnerability factors beyond age? Next slide. Well, dating back to Katrina, our attention was drawn to the difference between Caucasians and African Americans. We were also became very aware of differences in the sex of decedents. And what we've been hearing a lot about with COVID is that it's the men in the upper age brackets who are most at risk. Next slide. Next slide, please. So there's been growing awareness of the relationship, coming up between gender, looking at differences between men and women at age, socioeconomic status, and other kinds of personal variables. Next slide. And when we look at a number of comparable countries, what we see is something a little different in Canada than in other countries. In other countries, it's the men who are dying at more men than women. And in Canada, it's the other way around. And so, I'm a researcher. I ask questions, and I wanted to know. And I started to think, why is it? Why is Canada different than these other countries? Next slide. Next slide, please. And a major reason is that the majority of our cases have been in long-term care facilities. And we've heard a lot in the last little while. COVID has done us a favor in one sense, in that it has raised the profile of long-term care facilities and the dangers that exist in something like this kind of a pandemic. Next slide. Next slide, please. And this is data that shows the number of deaths in care facilities. And if you go down to the bottom right-hand corner, it says 85% of the deaths in Canada. So on the one hand, you could say, well, maybe we've got an overabundance of deaths in care facilities because we're doing a really good job of containing it in the community. So that's sort of the good news scenario. The other thing that we want to note when we look at this table is the percentage of care facilities that have had an outbreak. And when you look down that particular column, homes affected by percent, what we see is that it's not every home. So next slide, please.
Gloria, if you just click on the PowerPoint, you will have control to advance the next slide.
Okay, I'm clicking on the PowerPoint and it's not moving.
Okay, sorry.
Okay, so we want, why the high mortality rate in long-term care facilities? Why are some facilities having a problem, an outbreak, and others not? And so, the questions that I want to ask and want some answers to is it because of differences in the residents? Is it because of differences in the staff, in the type of staff, in the number of staff, in ownership? And for a long time, we've known that we tend to get more bang for the public buck from the nonprofit societies, that many of whom are doing a good job. But another question is, does it have to do with the physical design? Some facilities have more single rooms. Some have multiple rooms, which of course, from the point of view of infection control, you're going to have much better infection control if you've got a higher ratio of single rooms. Is it because of differences in the age of the building? Well, some of the older buildings maybe have different kinds of heating, ventilation, and so on. And I keep thinking about, Legionnaire's disease. Well, Legionnaire's disease turned out to be related to the water system. So have we looked at the difference between those buildings that have had outbreaks and those that haven't, to see if there are differences in the way that they deal with the air conditioning, that might affect the transmission. Another whole question has to do with the degree of disaster preparedness. And dating back to Katrina, I remember asking the Public Health Agency and asking various facilities, do you have a disaster plan in place? And I never really got a very good answer. So that's a question, you know, we as advocates for seniors need to ask in our own venues, to go around the facilities that are in our jurisdictions, to ask them, do you have a disaster plan? And do you have the various kinds of equipment in hand that you need in order to protect both your workers and your residents? So, you know, PPE, it has become a new acronym for many of us. Personal protective equipment, which these are things we didn't think about because for many years, what we've been saying is, well, you know, we're through with infectious diseases. It's chronic diseases that are going to do in most of our old people. And, you know, I remember hearing that, and we basically weren't thinking much about infections, even though every year facilities do have flu outbreaks. But we tended to sort of play those down and not think about them. And I guess what COVID has done is certainly say to us, we better be thinking more about infection control than we ever did before. So next slide, please. So this is an overview of when you have a disaster, and it shows that it's a function of the hazards, and we have on the right hand the various kinds of hazards, and of vulnerabilities. And if you go from left to right on this chart, you'll see that it includes political value, the valuing of older people, you know, and we hear a lot about ageism. So it's ageism comes in there in that left-hand column. If you go to the next column, it talks about urbanization. It talks about the increasing intensity of climate events and the frequency that we need to think about. The unsafe conditions talk about our buildings and how well they are designed for these kinds of disasters that we're seeing more of floods, of heat waves, of cold snaps. You know, many of us didn't think before, living in Canada in the, quote, frozen north, you know, we hadn't thought so much about air conditioning in the housing that we put our vulnerable populations. And certainly with the heat waves that we've seen in the last few years, more and more, we're thinking about, yeah, we better have good air conditioning because old people in a heat wave die at higher rates than other segments of the population. So this is a good diagram to sort of keep in mind and to keep all the pieces in one place. And, you know, it talks about, in this third column, poor support for older people, talks about lack of disaster preparation. These are the various things that we need to think about when we're talking about old people and disasters. Next slide, please. But now, what's the implications and how does this fit with elder abuse? Well, elder abuse happens in a variety of settings. It happens in people's private homes in their community. It happens in assisted living. It happens in long-term care. And it also can happen in hospitals. And when we're talking about elder abuse, you know, there's 5 types that are internationally recognized. So there's physical abuse, and that's the one we tend to think of, you know, that first. But there's physical abuse where somebody actually hits, burns, knocks over, trips, you know, does bad things physically to an older person. That's physical abuse. We've got psychological abuse, where you put a person down by making them feel like they're not worthy, that they don't have understanding, that they can't look after themselves, making them feel small and intimidating them. We've got financial abuse, we've got sexual abuse, and then we've got neglect. And in the institutional type of abuse, it's neglect that comes to mind. In COVID, we've been hearing about older people that were not getting sufficient care, that were sitting in soiled diapers for longer than they should have been, where people were not getting fed properly. So there's that kind of neglect that can happen in institutional settings. We also hear about some physical and psychological, and in that grouping, tend to hear now and again about older people being abused by staff. We also have in that category in institutions of aggression between residents. So of which is unfortunate indeed, and often it's because people are cognitively impaired and they become afraid and they strike out and they will physically abuse another person. So that falls also into the institutional settings. But when all is said and done, the vast majority of abuse tends to be psychological and financial. Those are the two most common. And unfortunately, the perpetrators, when all is said and done, tend to be people that they know, tend to be family, could be friends. But the thing that distinguishes elder abuse from garden variety discrimination, and that's in the definition, is that you call it elder abuse where there is an expectation of trust. So, as an older person, I don't expect that my kids are going to rip me off financially or that they're going to be mean to me. And so, it's a very difficult situation for an older person to have to admit that their children that are not being kind to them. So underreporting is definitely an issue. And so it's hard to get an exact number on how many people we're talking about. But it's probably in the area of about, could be between 10 and some people go as high as even saying 20%, 1 in 5 of our older people will experience some form of abuse. And many victims experience more than one type. So, there's not a lot of hard data when it comes to older people, but when you look at the data for child abuse and domestic violence, what we see in disaster after disaster is that they increase. So it seems to me reasonable to believe that we're also going to see increases in the rates of elder abuse. And we've already heard about neglect in institutional settings. What we haven't heard about in the news so far are increases in physical and sexual and psychological and financial. So next slide, please. But let's come back to the institutional settings. And during Hurricane Katrina, there was a lot of TV and newspaper reports about old people being abandoned and about, sexual, physical, financial abuse in emergency shelters, which I'll come back to in a minute. But we want to know, how many of these facilities, was it sensationalism or was it real? How big is the problem? when they had the nuclear disaster in Japan, one of the news reports was more than 125 elderly people, some even in a coma, abandoned by the medical staff. And that as a result, 14 of them died. Next slide, please. Next slide. Well, when all was said and done, actually, there were relatively few nursing homes that were in the case of Katrina, where there actually was a lawsuit filed that went to court. And there were very few people who, in fact, were indicted. And so the issue really was, what do we do? Do we shelter in place, or do we try to move these people? And in the case of the St. Rita's, in fact, they had had a hurricane before, where they had successfully sheltered in place. And so the owners actually had invited their grandchildren and their children to come and stay with them, because they thought they'd be better off than trying to evacuate them. So if we can go now to the next slide. This is the Astrodome in Houston. And so, you know, if you're a senior and you're living at home, do you shelter in place, or do you go to something like the Astrodome, where you're going to be on a cot in a big space? And you know what some of the data was showing, next slide please, is that in the Astrodome and in similar kinds of places, there were predators who came. There were people who preyed on those old people, on the frail, taking their money. And there even were some people from care facilities that were looking for business, and that went and tried to convince some of the people that were in these shelters that they should come to their care facility. And then when they got there, in some cases they took their money, and then they found if they didn't have enough to keep paying, they just dumped them back in the shelters. So people that were particularly at risk in these shelter situations were people with decreased cognitive functioning, the frail elderly, and people who were separated from their families, who didn't have an advocate, who didn't have somebody to look out for them, and they tended to be neglected. So, you know, we all hear about squeaky wheel. Well, if you don't speak up, and sometimes if you're just a quiet, nice guy, you don't get the service that you need. And that's what tends to happen to some people when they are evacuated from their home. So we need to think about the vulnerability of older people during the disaster. We also have to think about their vulnerability when they are taken out of the immediate disaster situation and evacuated somewhere. Are they going to get the services that they need? Are there people in place? Are there frontline responders who know what are the needs of old people, who understand old people? Or are they going to be underserved? And you know, we talk a lot these days about health literacy. You need to have enough literacy, health literacy, to understand when you're told about the risk factors, or you're told on how to get help. You have to be, for these days, to get services, you know, you really have to be computer literate, because you keep getting referred to go to some such and such website to download forms to fill in. Well, if you're undereducated, or if you're not very techno-savvy, as some of our seniors are, you know, some of them are really very good with technology, but some of them are not. Are they going to know where you apply, or what you have to do to get the services that they need? Next slide, please. So since Katrina, we have been more and more aware that seniors are not covered in all hazards and one-size-fits-all approaches. And that within the seniors community, there are some subgroups that are more vulnerable than others. The first thing that comes to mind and that we hear a lot about these days is social isolation. Seniors living alone who don't have contact with other people on a regular basis. So such social isolation, we've got people who are frail, we've got the chronically ill, we've got people who are cognitively impaired, people with early dementia, people with mid-stage that are staying in the community. So they're not only 5%, we have to keep remembering, of the older population live in care facilities, maybe another couple of percent in assisted living, but the vast majority of our older population are living in conventional housing, like you and I, in the community. And some of those people are quite frail and being maintained by, often it's an older man, like the picture in this slide, who's being able to stay in the community because he's got an old wife who's looking after him. And so you can have two frail people in the community, but they somehow seem to be able to cope under normal circumstances. But when you have a pandemic, it's asking them to take that extra step, and they don't have the reserve power. And so, you know, when you think about social isolation, think about the person who is able to stay in the community because they're getting home support. Well, in a pandemic, it may well be that that home support is turned off. So they're not getting home support. They're not getting able to go out of the house on handy dart to take the transit, specialized transit. Adult daycares are closed. So you're going to have a caregiver who may be more stressed out than normal because they're getting no break, no help from anybody else. So that's a risk factor for abuse. And there also are other groups within our seniors population that we need to think about. Those that have been exposed previously to traumatic stressors. So think about refugees. Think about people who went through the Holocaust, where they may have post-traumatic stress disorders, and sometimes the PTSD doesn't show up till years and years later when a person is in, again, a traumatic situation. Another group that I work with are the people who are part of the LGBTQ plus community. And there is some data which suggests that people from that community are more at risk because they've got the added stigma, they've got the added characteristics that may keep them from getting the services that they need. And many LGBT people have had bad experiences with our healthcare system, and so they're nervous to go forward and ask for the help that they need. So these are all vulnerable groups we need to think seriously about when we're in a disaster situation. Next slide, please. This slide shows the relationship between multimorbidity, having a number of chronic conditions, and socioeconomic status. And it shows very clearly that if you're in the top economic group, which is the black line, you're going to have fewer comorbidities at any age. So we really do have to think seriously about the people who are at the lower parts or are at financial risk. And, in a disaster, people with lots of bucks can take a taxi. They could take an airplane. They can drive themselves to another location if there's a flood or if there's a forest fire or those kinds of things. So you have more resources if you are in a better socioeconomic condition. And so we really do have to think about people who are subsisting in our communities, who are financially deprived, and who can't get services that others might be able to. Next slide, please. Coming back to people who live in collective settings, in long-term care or in assisted living, on the issue of loneliness, we need to think about the fact that many of them were lonely before COVID. So now they're coping with the fear that they might catch it. At the same time, they don't have the supports. They haven't got family visiting. There's no organized activities. And we really do have to recognize the extent of disruption for older people in collective settings, also those who are at home and who are getting home care, who don't have the relationships that they had and the day-to-day assistance. We also, from the point of view of abuse, have to think about that there's nobody coming into the house that can report, that can monitor. So that's we have the natural surveillance system of those of us who have relatives, who have advocates, who come into our facilities, who help out on a regular basis. Those are people who can be vigilant and who can monitor and keep an eye out for their loved ones, and who can ask for help when they think that the loved one is not getting what they should be getting in the way of services. Next slide, please. And then there are frauds and scams. And there was one in the Vancouver Sun back in early May talking about people that were being ripped off by fraudsters, the lonely people who thought they were buying a puppy for their relative, or where it's an older person that maybe thought, gee, if I have somebody to keep me company, a nice little puppy, and then they find that what they thought they were buying is not what they get, if they get anything at all. And the Canadian Anti-Fraud Centre has a website, and that's one that all of us should go to now and again to see what are the frauds and scams du jour. And there's a number that have come out around this time of COVID, like fake government and healthcare and research information. We hear from the USA a lot about fake news and about information that is not what we think it is. So we have to be as aware as our colleagues across the border and to resist getting suckered or sucked in by unsolicited calls, by emails and texts and so on, giving medical advice, or there's the grandparent scam. But the variation on it for COVID is somebody calls up and pretends to be your grandchild or your niece or long lost nephew, who says, I've got the disease and I've been laid off work, and if you love me, you'll lend me money. right, you'll help me out. That's in the olden days, you know, when I was growing up, it was sort of, you know, if you love me, you'll let me, as a way that some of our boyfriends took advantage of us. But with old people and financial abuse, you get family members, you get neighbors, you get long lost relatives who are fraudulently trying to get money from their older person. There are other unscrupulous people who claim to be that they're from some charity that's going to give them give masks or help in the development of vaccines. And we really do have to watch out for those ripoffs. Next slide, please. Next, okay. So these are just a few more, you know, door-to-door salespeople who come saying that they'll come and they'll decontaminate your house, or that they've got some fast COVID tests. Next slide. So this is not just a Canadian problem. Fairly early on, like, you know, back in March, I was hearing from colleagues in the UK and from colleagues in Serbia and from various places around the world where these same kinds of scams were taking place. And so, you know, we really do have an international problem here of unscrupulous people taking advantage of the disaster to try to sell our seniors on things that really are not what they appear to be. Next slide. So what do we do? What's the way forward? Well, you know, after Katrina, for the next few years, there was a big push on making sure that we took into consideration gender, recognizing that in both the pre-disaster situation, during the disaster, and post-disaster, we needed to have input from both men and women. We needed to think about the needs of men and women and to recognize that they aren't necessarily the same, and to provide gender training to our first responders. But it was interesting to me that although we see this, and if you could see the reference, you know, there was a whole institute on disaster and gender that has been established. So that was a big thing. But they didn't include age. So the way forward, we need to make sure that we are sensitive to differences between the needs and risk factors that affect men and women, and the different types of gender orientations. We need to be respectful, but we also have to make sure that we keep age in the equation and that it's loud and clear. Next slide. We need also to recognize that the risk and protective factors differ for different kinds of living arrangements and abuse types. So, you know, we hear a lot of this slogan, safer at home, to curb the spread of COVID. And but the potential for violence spikes when you're putting people together with someone who has been an abuser for 24/7. And that abuser could have been your spouse, could be a child, could be another relative, could be a paid caregiver. And so, you know, on the one hand, social isolation and living alone has, it sets you up where you could be at risk of financial abuse and getting talked into some fraud or scam. But on the other hand, you're not going to be abused or neglected by somebody who's living with you. So the different, the 5 types of abuse will have different weight depending on whether you're living in a collective setting or you're living alone. And we need to recognize that if we're going forward. Next slide, and this is my final one. Elder abuse, like COVID, has no borders or boundaries. We're seeing it worldwide. We're seeing that it includes victims from all socioeconomic classes. So yes, we have people who are in financial need who are more at risk than others, but still rich people also get ripped off, and so do movie stars. And so I would like you to see this clip. Those of you who are a little older will remember the people in the picture. It's Mickey Rooney, and he was a victim who probably drew the attention of the American government to the issue of elder abuse more than anybody else. So can we see this clip?
Good morning. It's a lovely morning. Good morning.
A song and dance man with a gift for comedy, Mickey Rooney made more than 200 movies. But today, he opened up about his family drama and the psychological abuse he claims he endured until just recently.
My daily life became unbearable.
Rooney, now 90, obtained a restraining order against his stepson last month, claiming the man had denied him of medication and food, had bullied and threatened him, making him effectively a prisoner in his home.
Even when I tried to speak up, I was told to shut up and be quiet. You don't know what you're talking about.
Despite his sunny roles, Rooney's off-screen life has been tumultuous. Married 8 times, struggling with drug addiction and a gambling habit that forced him into bankruptcy. He claims his current wife's son tried to take what he had left. The stepson denies the charges, but the actor today was adamant.
Money was stolen from me. Yet stolen.
Rooney came to Capitol Hill to shine a light on elder abuse, which affects an estimated 11% of the elderly every year, though no one knows for sure because so few report it.
Speak up and say I'm being abused. This happened to me.
Rooney says he himself waited years to come forward. Nancy Cordes, CBS News, Capitol Hill.
So this slide shows some resources that are available if you think that someone you know might be in an abusive situation, or if you yourself, as people watching, are concerned. So this is an Ontario Safely line. There are support lines in various of our provinces. In British Columbia, it's the Seniors First BC has the Seniors Abuse Information Line, acronym SAIL. In British Columbia, you also can get in touch with the person who is in charge of abusive situations in your local health unit. So you phone up the health authority and get connected with the point person there.
Thank you so much, Gloria, for the wonderful presentation. So what we'll do is we'll just offer a few resources at this time, and then I want to take some time. We have some really great questions here today. So as you can see on your slide, you just saw the Senior Safety Line, 24/7, 150 languages, only available in Ontario. We have some other great resources here, the Assaulted Women's Helpline, the Victim Support Line, and we'll move forward to some of the police resources. And here's some police resources. So depending on where you are within Canada, please make sure if the situation is critical or the risk is elevated to call your local police. And then we have provincial and national resources. So there is the Canadian Network for Elder Abuse Prevention and their website there. the NICE Network, which is the National Initiative for the Care of the Elderly. And please feel free to visit these excellent resources. And then we can never do a webinar without plugging our social media feeds. During this pandemic, our social media feeds have gotten a lot of traction. So you can follow us LinkedIn, Facebook, or Twitter. And of course, you can always reach out to myself or my colleague, Ray Ann, and there's her information there. And now it's time for questions. So I'll pull up, we have a couple questions here for Gloria. So Gloria, you're on in the hot seat now. So first question is, do you agree that family caregivers need to be recognized as partners in care at the table with legislative changes are underway?
Most definitely the family caregivers. Like I say, they are the surveillance system for people who are in institutional settings or in collective settings. And they also are the people on the front lines for seniors who are at home. So yeah, we need to support our caregivers. But we also need to give them a little bit of training to recognize the signs and symptoms of abuse and neglect, and to know where to go for help.
Wonderful. Okay, so this is a long question, so listen up, Gloria. Either long-term care needs to be incorporated under the umbrella of the Canadian Healthcare Act, or a standalone Long-Term Care Act, which aligns with fundamental principles of the Canada Health Act: equal and accessible health care for all, notwithstanding age, gender, color, affiliations, etc. Do you agree? And if so, how do we ensure that these basic principles are heard and acted upon by our elected officials here in Canada?
Well, there are many of us who for years and years and years have advocated to have long-term care included under the Canada Health Act. At this point, it is not. And so, the Canada Health Act will protect people in acute hospitals, but not necessarily in long-term care. And each province has health is a provincial matter, so each province has its own legislation. But what we need to have are some minimum standards. We need to have standards for things like the ratio of staffing, of direct care staff to residents. We need to have standards, and we need to have enforcement of those standards. In my own province of British Columbia, in the 1960s and 70s, when a long-term care program came in, we were the envy of the world. We had people coming from the USA, from Europe, from Asia, to come and look at what a good system we had. And over the years, there's been more privatization. There has been more a change. On the one hand, the good part of keeping more people at home. On the other hand, those who are in facilities are more frail than ever before. So, if you look at the lengths of stay of people in long-term care facilities over the last 30 years, you'll see that the lengths of stay have become shorter because people are more frail when they go into facility, meaning that there's more need for us to be concerned about protection. And in the case of this virus, protection not just for garden variety of kinds of abuse, but also for infections. So yeah, I would say we do need to advocate, and we've got a unique opportunity here. Because if we can keep long-term care on the front burner and not have it go back into the back burner, but keep it on the front burner so that we can get some of those changes put into place.
Thank you, Gloria. Now, next question is, When you see elder abuse happening in your own family, what action can you take? Can the police remove the person even if the person is being abused does not want that to happen?
Well, it's a very delicate situation. What I would advise is that if you think that someone in your family is being abused, try to get in touch with some professionals. We've just seen in the news these situations of so-called wellness checks that have had untoward outcomes. So you don't want to have the police running in. On the other hand, if you have an emergency situation and you really think the person is at risk, then yeah, do get in touch with the specialist within your local police department, or get in touch with the point person in your own jurisdiction. Try to get to the professionals and let them help, because you don't want to make the situation worse. If somebody is in a really dangerous situation and they are at the mercy of the abuser, you don't want to make the situation worse. So we have a responsibility to take action. We don't want, there's been research for years on bystander inattention or inaction. And in the case of child abuse, it's mandatory that you report it. In the case of elder abuse, we have 5 provinces where it's mandatory to report in an institutional setting, but we only have 1 jurisdiction in Canada that makes it mandatory to report community-based abuse.
Thank you, Gloria. We have a really great question here, and I'm really interested to see, to hear your response on this one. With long-term care homes having the highest mortality rates, what safeguards are now needed to protect the vulnerable who do not have access to means to be in touch with their family? While I understand the reasons for the restrictions, how can we do better?
Okay, those are tough questions. In the same way that in a flood, do you shelter in place or do you evacuate? In the case of contact with family and other loved ones, we have to be careful that we don't get them infected, or that they bring infection into the facility. But we also want to start figuring out, can we not give the people that are regulars that normally come in to visit their loved ones, can we not give them the opportunity, give them a couple of hours a day, give them protective equipment? It should be possible to do, because we don't want to make people more at risk of social isolation and of depression, of suicidal thoughts, or actually taking their own lives because they're so lonely and in such despair. So yeah, that's a very real situation. But that's going to take a partnership, in my opinion, between the family and the facility. And they need to sit down and figure out how to do it. And the excuse we're short-staffed is just not good enough. That's the excuse we get all the time. Whenever there's a problem in long-term care, oh, well, we haven't got enough staff. And particularly in the case of privatized facilities, pay your staff a little more or hire some more staff. And again, we need to go back to that issue of the ratio of direct care staff to patients. So unless you make it clear that it's not the gardener that you count or the maintenance worker, but it's the direct staff. How many hours of direct staff have you got in your employ? Are you paying them enough that they don't have to take jobs in several places? Are you paying them enough so that if they're sick or their kid at home is sick and they're going to put germs into the facility, that they can still eat if they don't work? So, decent wage, we need to respect the workers that are on the front lines, the care aides, the porters, the people, the nurses who are in the staff component of facilities, and make sure that they have the security so that they will stay home when they're sick. We have flu epidemics every year, like I said before, and we haven't thought enough about it. How did the flu get into the place? Did it come in by staff? Did it come in by some a grandchild with a runny nose? We need to think more about screening. It's only recently that we have in many of our facilities required that they do a background check to make sure that staff don't have a criminal record. We need to look at their health and screen them for potential infectious diseases, and to make sure they have the right kind of orientation to dealing with this population, and the right training. So we need enough staff with the right training at the right time and place.
Thank you so much, Gloria. We had some wonderful questions today. I do want to be cognizant of the time. We are almost 2:10. So I think we're going to wrap up today's webinar. I do want to remind all of the attendees still online that our webinar the recording of the webinar will be made available on our website and social media come Monday. So thank you so much for joining in today. Gloria, thank you so much for joining in. You're a wealth of knowledge. And a reminder to everybody, there is an evaluation as soon as this webinar is over. So I encourage you to fill out the evaluation. We really want to hear your feedback and ideas for upcoming webinars. Thanks again, everyone. Have a good day. Take care.